Okay, thank you everyone for your patience. We are in process of uploading the slides. Oh, that was faster than I thought. Dr. Oliver is going to run through, in order to address all of the concerns of the committee and our liaisons, we wanted to make sure that we had the best possible set of recommendations moving forward. We recognize there's going to be limitations to all of this and within the constraints of the FDA EUA, but I will just say that we are going to try and take a series of staged votes. Dr. Oliver will walk through the thinking behind the votes. We'll open it up for a brief discussion, and we'll kind of walk through the votes one by one and do our best to be out soon.
Yes, and I'm going to add to Dr. Lee's comments that we can remember that we're voting on the intent, and some of the language can be wordsmithed after votes as we're working on finalizing language before. And I'm going to hand it over to Dr. Oliver.
Thanks so much. Next slide. So this is just a reminder of the type of recommendations that ACIP can make today. Next slide. Oh, next slide. Okay. So the first vote that we will propose today, language is a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons aged 65 years of age and over and long-term care facility residents at least 6 months after the primary series under FDA's emergency use authorization. That was the policy question number 1 that we discussed. Next slide. We heard support potentially for a full recommendation for those 50 to 64 with underlying medical conditions. So this is another option. A single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons aged 50 to 64 years with underlying medical conditions at least 6 months after the primary series under the FDA's emergency use authorization. Next slide. Then based on discussions, we have this is the vote 3, a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons based on individual benefit and risk who are aged 18 to 49 years with underlying medical conditions at least 6 months after the primary series under the FDA's emergency use authorization. Based on the results of vote 2, the ages included in this could be adjusted if needed. The next slide. The fourth vote that we have proposed is a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended based on individual benefit and risk for persons aged 18 to 64 years who are in an occupational or institutional setting where the burden of COVID-19 infection and risk of transmission are high, at least 6 months after the primary series and under FDA's emergency use authorization. So I'll turn it back over to Dr. Lee to facilitate discussions around the proposed language for these votes.
Sure. I think at this point, are there any, are there any voting members who wish to make any comments about any particular one of these votes, recognizing we're going to go through this series of them, and so we can have the opportunity to discuss a little bit more. Dr. Long?
Clarifying question. None of the recommendations say anything other than after the primary series. Does this, it should say, if you mean it, primary series of Pfizer-BioNTech COVID-19 vaccine, or are we going to have a separate vote about mixing and matching?
Thank you.
I wouldn't be able to vote with this on any of these without that clarification. Thanks.
Thank you, Dr. Long. For simplicity, we are focusing on the vote language to make sure we have the language correct. Implied would be after a primary series.
And just to clarify even more, implied is a primary series after the Pfizer vaccine. We are not voting on mix and match today, and I know everybody we've heard your voices loud and clear, and but today this is the question at hand, and we will come back soon with other questions.
Any other clarifying questions, Dr. Lair?
I don't see any comments or votes about a permissive language. Would those come if some of these votes didn't pass?
If you go back to number 3 and number 4, so thank you for asking the question. Dr. Cohn briefly described the history of what used to be known as Category B, what used to be known as permissive, what used to be known as shared clinical decision-making. And in this ETR framework, we have adapted it to instead specify individual benefit and risk. And we can go through some of the history and the methods around that, but I think it was meant to be that middle category for both vote 3 and vote 4.
And this is Dr. Oliver. I'll clarify. For this vote 3, the age is for the vote 3 will be based on the outcome potentially of vote 2. So there could be fluctuation based on, how the progression of the votes go.
Did that clarify, Dr. Lair?
Yes, it does. Thank you.
Okay. I think what I'd like to do actually is ask Ms. Hayes, is there a clarifying question you have?
Yes. I'm curious why the language says 18 and over in the options 2, 3, and 4 when the BioNTech vaccine is approved for people 16 and over. So was there a rationale for upping it to 18?
Yes, so the EUA for the booster dose is actually 18 years of age and up. That is the reason why we're saying 18 and not 16.
Thank you.
Okay, thank you. I think what I'd like to do is ask if any of our voting members would like to, let's go back to vote 1, thank you, would like to make a motion before we move to a vote, we will give the voting members an opportunity to discuss the motion on the table. So, Dr. Alt?
I move that we accept the language on this slide for vote number 1.
Thank you, Dr. Alt. Would anybody like to second? Dr. Paling?
I would like to second that vote.
Thank you. It's moved and seconded that we adopt the recommendation language presented here for vote 1, which is a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons 65 years and older and long-term care facility residents at least 6 months after the primary series under the FDA's EUA. Before we move to a vote, I'll invite our voting members to discuss the motion on the table. Are there any additional questions or issues the committee would like to discuss before this vote? Dr. Lair.
A small point, but I'm very sure I'm going to get questions when they ask about primary series. So I suggest that we do what was recommended by saying primary series of Pfizer-BioNTech, that other people won't be confused.
Thank you, Dr. Lear. We'll make sure that that is clear in our overall language surrounding these votes.
Thank you.
All right. Seeing no other hands raised, I'll assume the committee's ready for a vote on the motion on the table. Assuming there are no objections, I am going to ask our ACIP members to please state your name, whether you have a conflict of interest, and then your vote. We are going to start in alphabetical order this time going forward. I won't confuse anyone. Dr. Alt?
Are we videoing? Yeah.
Apologies. Thank you. If everyone could put your video on.
Dr. Lee, do you want me to go ahead?
Dr. Alt, that would be wonderful. Your name and conflict of interest in your vote.
Alt, no conflicts, yes.
Ms. Bata?
Bata, no conflicts, yes.
Dr. Bell?
Bell, no conflict, yes.
Dr. Brooks?
Brooks, no conflicts, yes.
Thank you. Dr. Chen?
Gilbert Chen, no conflicts, yes.
Dr. Sineas,
Sineas, no conflicts, yes.
Dr. Daly,
Daily, no conflicts, yes.
Dr. Cotton,
Camille Cotton, no conflicts, yes.
Dr. Lair,
Jamie Lair, no conflicts, yes.
Dr. Long,
Sorry. Dr. Long, no conflict, yes.
Ms. McNally,
McNally, no conflicts, yes.
Dr. Paling,
Healing, no conflicts, yes.
Dr. Sanchez,
Sanchez, no conflict, yes.
Dr. Talbot,
Talbot, no conflicts, yes.
and Lee, no conflicts, yes. So there are 15 who voted yes, 0 no's. The ayes have it, and I believe the recommendation is adopted. Dr. Cohn?
Yes, this motion passed 15-0.
Okay, thank you. Are there any brief comments any committee members would like to make on this particular issue? Okay, great. I've just been asked to move all the comments to the end, so we're going to go through the votes, but we will have an opportunity to discuss the vote on the table. Let's move to ACIP vote number 2. Okay. Vote number 2 is up on the screen. Are there any members who wish to make a motion for vote number 2? Dr. Paling.
I'd like to make a motion to adopt as is written. Thank you.
Thank you, Dr. Paling. There's a motion on the table. Would anybody like to second it? Dr. Daly.
I second the motion as written. Thank you.
Thank you, Dr. Daly. So this motion for vote number 2 has been moved and seconded, that we adopt the recommendation language presented here. A single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons aged 50 to 64 years with underlying medical conditions at least 6 months after the primary series under the FDA's EUA. Would any committee members like to raise any issues or have any further discussion for this particular vote on the table? And there are no hands raised. I will assume the committee is ready to vote on the motion. Are there any objections to proceeding with the vote? Okay. We will move forward. ACIP members, please again state your name, whether you have a conflict, and then your vote. So we'll start with Dr. Alt again.
Alt, no conflict, yes.
Ms. Bata?
Bata, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, no.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Chen?
Chen, no conflicts, yes.
Dr. Sineas?
Sineas, no conflicts, yes.
Dr. Daly?
Daily, no conflicts, yes.
Dr. Cotton?
Cotton, no conflicts, yes.
Dr. Lair?
Lair, no conflicts, yes.
Dr. Long?
Long, no conflict, no.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Paling?
Healing, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Talbot?
Talbot, no conflicts, yes.
And Lee, no conflicts, yes. So I count that there are 13 yeses and 2 nos. And the ayes have it, and I believe this recommendation is adopted. Dr. Cohn?
Yes, the motion passes.
Okay. All right. We are trying to work through the votes and the discussion that needs to take place. We are going to, since vote 2 has passed, vote number 3 has been put up on the table, and I promise there will be discussion. I just want to make sure we capture all the committee members, as I know some might have to leave near the end of the session, so I want to make sure we get through the votes and that everyone's opinion is heard. So are there any committee members who wish to put forward the motion that is written on the screen there for vote number 3?
This is Brooks. I move to approve or put on for a vote ACIP vote number 3 on our recommendation as presented.
Thank you, Dr. Brooks. Do I have a second? Dr. Alt?
I'll second Dr. Brooks' motion.
Thank you. It's moved and seconded that we adopt the recommendation for vote number 3 listed above. Just going to hit the highlights that it's recommended for persons based on individual benefit and risk who are aged 18 to 49 years with underlying medical conditions. And the remainder of the text remains the same. We are going to go through once again. Oh, I apologize. Yes. Thank you. Are there any comments or discussion that we need to have regarding this particular vote?
I just have a clarifying question. Is this a recommendation or a permissive or whatever language we're currently using for permissive? Thank you.
Dr. Oliver, do you mind putting up that middle slide, that slide with the gradient?
Back to the first slide.
While we're pulling that up, in short, the intent of this recommendation is that middle category, what we called permissive, but we know that can be a challenging word, and so we're calling it an individual, depending on an individual's risk and benefit.
Yes, the balance of benefits and risk in that middle category is the language, the intent of this vote, and we'll make sure that is what is communicated if this passes.
Thank you.
Dr. Cotton?
Could you just elaborate on the difference between, is this shared decision making, and if so, is that the intent, or is this not shared decision making?
Thanks, Dr. Cotton. Part of this is it is the shared clinical decision making kind of as ACIP typically uses. We know, and the work group had many discussions around this, that in the setting of COVID vaccines, many of these are not necessarily happening in a provider's office where everybody is having kind of that shared decision-making discussion. And so that was one of the reasons that the language changed slightly to kind of this individual benefit and risk, that there may be a lot of factors that go into it, but the onus is not on the individual to have a discussion with the provider, necessarily before they fall there. So some of this is just the unique setting and the acknowledgement that, the COVID vaccine program and time right now is just a little bit different than it has been in the past. But yes, it is kind of the framework structure that the shared clinical decision making has been built on in the past.
Are there any further questions or clarifications needed? Dr. Daly.
Yeah, could you put back up that slide again? Sorry, the one that we just had up with. So, to be honest, I've struggled with this, and I think I realize that one of the reasons I struggled with it is because there's just a great deal more uncertainty here. And so then in that context, I appreciate that the members of the ACIP have a varying range of opinions about this. I think for me, I do think there's individuals who are 18 to 49, for example, a 35-year-old with cystic fibrosis who may benefit from a booster. And so I'm trying to keep that in mind, but I recognize that fortunately the primary series is providing good effectiveness and there's a lot more uncertainty here. Over.
Dr. Long?
I reflect that thought of Dr. Daly's, and also I don't know, I hope everybody has seen what I think I saw as we went through, that there was as we went down in age, having no data that those who have underlying medical conditions have a more rapid wane, especially in very young individuals, and knowing that the risk of myopericarditis in the 18-year-old age group is substantial, I agree that this is not a simple decision, and I know everybody takes this at least as seriously as I do. I didn't mean that, but we got so taken up with discussing some of the other things. I don't think we really talked about this. The 50 was suggested, and we didn't really talk about those younger much. Thank you.
Thank you. Dr. Bell?
Oh, yeah, a sort of a question clarification and a suggestion. The question clarification is, if I understood Dr. Cohn correctly a few minutes ago before our break, if ACIP does not make some sort of recommendation for whatever, the vaccine is actually not available to anyone because this is under an EUA. In other words, with a BLA approval, anybody can go get a vaccine, even if it's not recommended by ACIP. But in this situation, if we do not make some sort of recommendation that for a population, then the vaccine is actually not available to that population as a booster. Is that correct?
So given, I hope I'm saying this correctly, but given the, because of the PrEP Act and the fact that this vaccine is being covered by the PrEP Act under, and is both an EUA and and this is a government program, so it's all public vaccine, that means that providers have been, the providers are bound to provide the vaccine under the EUA using ACIP's recommendations. So if the committee voted no, there would certainly be it would be challenging to sort out the implications with a different FDA age for approval for authorization versus an ACIP recommendation. However, if the committee does vote no, this is also an interim recommendation that can be come back to in the future, which could be a couple of weeks away when there's more data. If so it shouldn't drive your vote, is what I'm saying, but it could limit access.
Okay, thank you. And then is there a time in this whole process where if we wanted to, for this particular recommendation now on the table, amend the age group recommended, for example, say age 30 or something like that rather than 18? We don't do that now, right? We have to vote on this, and then we would go back if there was some interest in doing that. Is that right?
If there was an interest in amending this to start at age 30, for example, somebody could put an amendment on the table, and if that was seconded, what we would do is vote on the amendment first. And so we would vote to decide if you were going to change that 18 to age 30. If somebody didn't put an amendment on the table to vote on, then we would vote this language as is, and if it was a no vote, we could then put a separate a vote on the table to change the age as well. So there's two different ways to consider changing the age group.
Dr. Bell, is there anything else?
I'm hesitating about making an amendment that just complicates things further. So I think maybe I'll just be quiet for now.
Thank you. Thank you for your questions and for clarifying for all of us. Are there any other questions or issues people would like to discuss before we move to a vote? Okay, seeing no hands raised, I'm going to go back to our ACIP members. As a reminder, your name, conflict of interest, and then your vote. Dr. Alt.
Alt, no conflict, yes.
Ms. Bata.
Bata, no conflicts, no.
Dr. Bell.
Bell, no conflict, no.
Dr. Brooks.
Brooks, no conflict, yes.
Okay. Dr. Chen.
Chen, no conflicts, yes.
Dr. Sineas.
Sineas, no conflict, yes.
Dr. Daly.
Daily, no conflicts, yes.
Dr. Cotton.
Cotton, no conflict, yes.
Dr. Lair.
Lair, no conflicts, no.
Dr. Long.
Long, no conflict, no.
Ms. McNally.
McNally, no conflicts, no.
Dr. Paling.
Paling, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict. No.
Could you restate that, please, Dr. Sanchez?
Oh, I'm really torn.
Okay.
So Sanchez, no conflict, no.
Okay, no. Dr. Talbot.
Talbot, no conflict, yes.
Lee, no conflicts, yes. So I count 3, 6, 9 yes and 6 no's. So the ayes have it, and this recommendation is adopted.
Yes.
Okay, Dr. Cohn, we'll move on to vote number 4. All right. Oh, sorry. Okay, I'm going to read this one because this is actually the one I think that required the most consideration or brought up the most discussion. So the ACIP vote number 4, a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended based on individual benefit and risk for persons aged 18 to 64 years who are in an occupational or institutional setting where the burden of COVID-19 infection and risk of transmission are high, at least 6 months after the primary series under the FDA's EUA. So, would any of our voting members like to make a motion? Dr. Long. I think you're still muted,
You're
Dr.
muted.
Long.
Dr. Long, you're still muted.
I do not choose to make a motion.
Okay. Dr. Alt?
I move that we accept the language on this slide.
Okay. And Dr. Long, we will come back to you. Is there a second for the motion on the table?
Camille Cotton, I'm happy to second that.
Okay, so we have, it's moved and seconded that we adopt the recommendation language presented by the work group. Before we move to a vote, I'll ask our voting members to discuss the motion on the table. And Dr. Long, I'm going to go back to you first.
Yes, I expected in the language for persons who are at occupational institutional risk, who are themselves at risk of severe disease. That's what the FDA said.
So given the many
So
other...
individual benefit and risk doesn't quite do it for me.
Okay. Thank you, Dr. Long. Are there any other comments or discussion? Dr. Fink, would you like to respond?
Sure. Maybe I can try to clarify that a bit further. So what the bullet in the authorization population speaks to is a risk of serious outcomes of COVID, which include severe COVID, but are not limited to severe COVID. And that risk is a function of frequent exposure to the virus that cannot be avoided.
So I just want to add that we proposed this language to take into account some of the other additional considerations that ACIP can consider that FDA doesn't consider, such as workforce capacity, and other things such as frequent exposure to unvaccinated persons, or in places or settings where there's not other social mitigation methods. So it's still an individual choice or decision around getting vaccinated, but it is in these settings where there could be increased exposure and a high burden of COVID infection due to their occupational or institutional setting.
Thank you, Dr. Cohn. Dr. Paling.
So I want to ask a clarifying question. So persons that work in or are incarcerated, they would have a choice to get a booster if they were received Pfizer more than 6 months ago. Is that the intent of this?
Yes. So that would be included in the intent of this recommendation.
Dr. Dooling will comment just briefly. She wanted to go over the examples that were given in her slides.
Sure. Just to refresh your memory, this risk-based group, which includes occupation or setting, was for people 18 and older, and included fully vaccinated persons who might be at risk of SARS infection due to occupation or setting, or absence from occupation due to infection. And the examples that were given were essential workers, both frontline and non-frontline, unpaid caregivers to frail or immunocompromised persons, paid or unpaid workers who interact with sick people within 6 feet in the course of their jobs, and people who live in congregate settings such as homeless shelter or correctional facilities.
Thank you. And actually, there was another question. We just want to clarify that ACIP vote number 4 is focused on that middle box of that gradient. So this is individual benefit and risk. Similar to our prior shared decision-making recommendations, AKA category B, AKA permissive, but we are focusing on individual benefit risk balance here. Are there any other, Dr. Long?
Yeah, I'd just like to say again that, well, now that I've heard others speak, I think it's just so open-ended in the way it is stated that, again, we have people who, you know, somebody mentioned you're 18 years old and you work in a shelter. Well, you've been vaccinated. I mean, these are not unvaccinated people. These are properly vaccinated people. We know that their risk of breakthrough is very low. We know that their likelihood of being severely ill is very low. And we know that these are groups at which there is some unknown risk of adverse events associated with the vaccine. So I think this one is an extremely slippery slope that is very difficult to interpret. I know all the practitioners in the group will just say, you just give it to everything, because who isn't exposed to the community that you might consider that at risk, or who might be anxious about it and there's no risk. It just seems uncharacteristically openly ended for the lack of data of need in any of these groups.
Dr. Sanchez?
Thank you. I really want to echo Dr. Long's comments as well. I mean, we might as well just give it to everybody 18 and over, or just anybody who walks in and says, hey, let's just give it. And I think we have a really effective vaccine, and it's like saying that it's not working, and it is working. And so certainly some higher risk individuals who do have some waning immunity with time, yes. But I just think that we're really going to almost like, if you want to just take a third dose. And so I am concerned about this.
Thank you, Dr. Sanchez and Dr. Long. I'm actually going to just chime in to state that I very much want to emphasize, especially to our clinicians and to the public, that the benefit risk balance really is individualized. In particular, we have discussed previously the risk of myocarditis following vaccination, and there are many uncertainties around that. And so I do want to make sure that if individuals choose to receive an additional dose, that they really do weigh those benefits and risks to themselves, particularly if you're younger and if you are male, for example, receiving an mRNA vaccine. I will also say, though, that there are many individuals, patients, and scenarios where I do believe access would be helpful to individuals and their families. And so I also feel very torn about this, but I am in favor of it in part because I feel like in this case, access, outstanding patient education, public education, provider education is needed. If we can do all of this together, then it does preserve access for individuals who may be at risk. Dr. Brooks.
Yes, and I apologize if there's ambient noise. I speak in favor of the motion. Everything that everyone said thus far has been basically true. I believe that this is the conundrum that we have. These are difficult decisions. So therefore, it is an individual benefit and risk determination that is made. So if you're 18 and you work in a shelter, but you feel you need a booster, then that's the individual decision. I don't believe everyone that's 18 that works in the shelter is going to go get a booster. But there may be someone that is 64 that works in a shelter and says yes. So I think the language speaks to everything that people are saying. So it's a difficult decision, but that's where we are right now in this pandemic. So it allows for all the variety of discussion positions that have been stated.
Thank you. Dr. Cotton?
I just wanted to highlight that I understand that this is a huge category of people. Nonetheless, I think it may be one of the ways in which we can better protect the estimated 3% of U.S. population that is immunocompromised, who are at higher risk, may not be well protected even after a third dose of vaccine. And better protecting the people around them may help protect them. We call it cocooning the patient is a common concept. So if we protect the people around them as best we can, that may be one of the better methods to protect the immunocompromised. Thank you.
This is Dr. Cohn. I just want to make one more comment before you all vote, which is just to remind everyone, and we talked a lot about this yesterday, but haven't really come back to it today, that vaccine safety is really is our top priority. And as individuals get boosters, we will come back to ACIP with vaccine safety data in the very near future. And if there are any concerning signals or increased risk of myocarditis in persons who receive this, who are younger, we will immediately bring that data to you and for your consideration. So I just wanted to reassure everyone that just like during our original rollout, vaccine safety will remain our top priority.
Dr. Sanchez, did you still have your hands raised, or did you want to make another comment?
Yes, yeah, thanks, Dr. Lee. I just wanted to, two things. First of all, I'm not sure that this takes into effect the cocooning effect, at least for pediatric patients, because those parents may not be in or whoever the caregiver may not be in an occupational institutional setting. So I think that there is a little bit more, and certainly I would agree with the cocooning effect, but I'm not sure that this really takes that into account. But the other thing is that with a lot of the vaccine mandates that are being proposed and implemented including healthcare places, I do think it's going to be important if this does pass about the fact that a fully vaccinated person has received, it's not a booster dose included in there. Because I think that is going to be very problematic if we don't ascertain that.
Thank you, Dr. Sanchez and Dr. Cotton. I actually agree with you very much, taking care of some pediatric patients who have really suffered from severe COVID complications. Dr. Cohen, my question to you is, do we need to leave the word institutional in there, or can we say occupational or setting where the burden of COVID infection and risk of transmission is high?
We could change the language, and this would be wordsmithing and not substantially different, to say recommended based on individual benefit and risk for persons aged 18 to 64 who are in an occupation or setting where the burden of COVID-19 infection and the risk of transmission are high. That language, we would have to go back. I think we can vote on that language if that's what people prefer. We would have to go back and make sure that is well aligned with the FDA authorization, so we might have to wordsmith some additionally. But if that's the intent, to be more expansive with that setting and not just in institutions, but in some of the settings, other types of settings you've raised, we can do that.
Thank you. Dr. Sanchez and Dr. Cotton, would that address the concern?
Yes.
Yeah.
Thank you. Dr. Long, you have your hand raised.
Yes, I'm sorry. I just want to be absolutely clear. As I understand this, and as I understood Dr. Fink, we will be expanding on the FDA approval. And I understand that we can do that, but it is very unusual that we let light shine between the FDA and the CDC in the expansion department. So this does not include at all the requirement, as I understand it, for risk of severe COVID disease. When one just says individual benefit, 18-year-old is anxious, we're not protecting, we're not providing anything extra for that individual in the benefit department, except for maybe relief of anxiety, but we are providing risk. And I just think that's very unusual for us to do, to let individuals decide on vaccine policy. I'm not going to say any more.
Dr. Long, you can always speak up. Understood. I do think that there has to be some reconciliation that will happen. I do think, though, what we would like to do, or what I would like to do, is make sure we vote the intent, and then we would seek additional guidance from our CDC and FDA colleagues to ensure that the intent is as written, but we will give some time to that. Dr. Cohen, do you want to?
Yeah, so to stay within the intent, I understand that this isn't addressing Dr. Long's concern about the high risk for severe COVID, but to stay within the intent, I would like to add back occupational or institutional setting, just so we're not expanding that word setting too much, and we will continue to, these recommendations will continue to evolve.
Dr. Duchin, did you have a comment?
Thank you. I was going to comment, but I think Dr. Cohen addressed my concern. Thank you.
Thank you. Ms. McNally.
This is challenging because I think that we're making some assumptions about health literacy that may be problematic, and I think the implementation on this is going to be very challenging. Thank you.
I 100% agree with you, Ms. McNally. I know. I struggle between how much do we assume and enable or not enable access versus how much do we have to be able to move forward and put all the tools we can, which will never be enough out there, to ensure that everyone is fully educated on the benefits and the risks. Ms. Stinchfield.
Yes, Patsy Stinch from NetMap. I want to just add, in terms of implementation, the proof of your risk in a setting, a clinical setting, a public health setting, pharmacy, is next to impossible. Having done a lot of mass clinics, both for healthcare workers and in the community, to have someone have to go to their clinician and have a document of what their risk is and then bring that to a community vaccine setting, I think would be an undue stress on a very stressed out healthcare system right now.
Thank you for that comment. Approximately 70% of COVID vaccines are now given in the setting of a pharmacy. And as with primary series, any booster would require self-attestation and not any additional onus for documentation.
Thank you.
Thank you. Dr. Chen.
Yeah, I was going to save these comments for after the vote, but I guess I wanted to share them now, which is that, I've been very uncomfortable with I guess, my own thinking through even vote number 3, and now more uncomfortable for vote number 4. We start moving into the territory where we're really not talking about direct benefit to the person who's being vaccinated. We're talking about indirect benefit to the people surrounding them. And we know that indirect benefit is largely to be gained by people getting their primary series, and it's not the answer to give them boosters, especially for this age group that doesn't have underlying medical conditions. They don't have predictors that would put them at the highest risk for severe effects with COVID infection. So I guess that's why, we start moving into this territory where I feel very uncomfortable about this. And again, I think we've already said this as well. The implementation part of this is going to be fraught with such complexity that basically the people who have great health literacy will get boosters. And they're not really the ones that are going to get best, incremental benefit out of this, nor indirect benefit for the people around them. It's still really the people who have not gotten vaccinated yet. So anyways, I'm just expressing my kind of uncomfortableness around this particular vote. Thanks.
Thank you, Dr. Chen. I'm sure you are not alone in your discomfort. Dr. Dries.
Yeah, thank you. From a healthcare workforce perspective, I think while I agree with Dr. Long that most of these people are not at risk for severe disease, we do certainly see them getting infected at increasing rates this last month or so, even though they are fully vaccinated. And it's difficult to predict which ones will develop long COVID symptoms. And so I feel like, they've been on the front lines of this from the beginning. And even though we have PPE and they use their PPE to protect themselves, it's very frustrating and demoralizing for them to get COVID anyway. And again, there is still that personal risk of we have had some severe cases, but also of long-term symptoms. So I think that it's reasonable to include them in this vote. Thank you.
Thank you. Dr. Long.
Yes, I hear that, and I also understand the adults who stepped up and were immunized, and partially for their own protection, partially for that of their neighbors and citizens. But this is not the vaccine we have to do that. This vaccine will not reliably. We know people who have been infected 2 and 3 and 4 times already, or immunized and infected twice. So that disease is almost always mild, and in the younger age group would be very unusual if it weren't, if it led to hospitalization. So, our goal is to protect, I think, from death and to get everyone immunized so that we can use the vaccines that we have at hand to protect from severe morbidity and death, and then not have to worry about who has coronavirus, who can't go to school, and those kinds of things. So we have to do that with primary infection and prevention of the worst cases, which are, no doubt about it, going to be the most contagious. But I don't think this is the vaccine that I'm thinking is going to do anything to protect against acquisition or transmission for more than a couple of months, even the booster. So I agree with you. I just don't think we have the vaccine in hand. Thanks.
Thanks. I do want to just reflect that this is not an either-or vote. As I said before, I think the primary focus of public health should and will remain on the primary series, and there is ample supply. So I do appreciate all of those concerns, which are extremely important. But this vote is to allow an individual who is in one of these settings to make the decision to get vaccinated and have access to it, and shouldn't take away from our public health efforts, and won't, to increase the primary series.
Thank you. Dr. Shaw?
Thank you, Dr. Wee. I'll be brief, and my comments echo some of what has been said from a state health department, and dare I even try to speak for local health departments as well. From an implementation perspective, this will be exceedingly challenging. The analysis required to effectuate this recommendation proceeds along two axes. The first is the pros and cons of the individual benefit determination, and then secondarily, or in concert with that, the nature of the occupational and institutional risk. Many patients themselves may not know exactly what the components of the individual risk determination are, let alone their occupational risk. Even if the patient were to know that, the individual staffing the pharmacy that day or at the large-scale vaccination site may themselves not have the wherewithal to make that determination and effectuate it in the manner that the committee may intend. So from an implementation perspective, this would be exceedingly challenging. Even though I certainly agree with the public health spirit underlying it, from an implementation standpoint, this would be a lift and would result in the inevitable confusion and patchwork that we saw back in January and February.
Thank you. Dr. Zahn?
Yeah, so I guess following up with Dr. Shaw, I'll speak for the local public health standpoint and to testify that, yeah, this would be, this is going to be just extraordinarily difficult to implement. I think it would essentially be, you would be communicating to individuals, assess your own situation and get vaccinated if you think it's appropriate, which is really complicated. The other point is I think Dr. Chen sort of got at a point which I worry about from my side, which is we vaccinate people to protect themselves. And so given that we, as I think Dr. Bell mentioned earlier, most of the high-risk situations, we're talking about the people actually acquire infection, for example, healthcare workers at home primarily. I mean, that's their primary risk, or in the community. And so, to me, when you talk to people about getting vaccinated, you really talk to them about their own risk and themselves and whether they should get vaccinated. And I think from a public health standpoint, it's going to be really important. If we're recommending a vaccine, we're recommending it because it's a good thing for them, rather than it is a good thing because, they'll be able to show up, or be, more consistently available as part of a workforce, if that makes sense. I think it's a very hard recommendation not to say that. And then once you say that, it seems to me generally we're saying eventually we're talking about recommending vaccines just broadly, for the community. It just, this feels like a very large step toward that direction, and I can understand that, but that's a very, this is a big decision to make in terms of, what direction to go, I just think.
Thank you. Dr. Talbot?
I understand I appreciate everyone's angst because I have a fair amount myself. But that being said, we are hoping locally to vaccinate our healthcare workers, knowing that they're not getting it here at work, they're getting it at home because their kids are in schools and there are no masks and their kids can't be vaccinated. And the longer that they're symptomatic, or the more often that they capture even a mild illness, it means they cannot come to work and we cannot continue to staff our hospital. And it's not just here in Nashville. Other states are experiencing the same thing. Having the ability, the option to give the healthcare worker the third dose, not mandating it, but giving that option helps us maintain our staffing. And I'm sure we are not the only one. And so I think there are caveats, and there's probably groups that may or may not be the best fit for this recommendation, but I think the healthcare workers are critical and cannot be forgotten. Thank you.
Dr. Goldman, and then I think I'll make one last comment, and then we'll wrap up and try and move this to a vote, and we'll see where things fall. Dr. Goldman.
Thank you, Dr. Lee. Be real brief. I really think this is a solution looking for a problem. I don't think it's going to address the issue of the pandemic. I really think it's just going to create more confusion on the provider and physician implementation level. And I really think it's going really far afield of the data and what we are trying to accomplish from a public health perspective. So I think we just need to be really cognizant of that fact, as I'm sure everyone is, and really do what's best for the public health and really stick to where the data takes us. Thank you.
Thank you. I just wanted to make one personal comment, which is I do not support this as a full recommendation because of all the concerns that were brought up today. My own personal experience has been that I have cared for children who have died from COVID, and I can tell you that their family members really wished that they didn't have that they had extra protection for their kids because they weren't symptomatic. Nobody else was really sick at home. And I think the idea that some family members wish to provide this extra level of protection and are willing to take that risk, I wish that we could enable that to happen. And hence, for me, access is really important. And I do worry that by inhibiting access to this, some individuals and families may suffer. That's just my own personal experience for why, but I also have all the same concerns about safety, health literacy. Does this make sense from a population perspective? No, which is why I think this is under the individual benefit risk balance consideration. So again, if this were a full recommendation, I personally could not support that. I see this as different because it is an individual benefit risk decision. I also recognize the complexities of implementation and realize that there's a lot that needs to get done in order for us to do this well. Dr. Daly, do you have an additional comment?
Well, just that I'm struggling with this as well. And one other consideration is that it feels broad enough that it could potentially limit access to other groups, those over 65 and those 18 to 49 with high risk conditions, for example. So I appreciate the intent of this, and I also think we need to think very carefully about the healthcare worker workforce and staffing issues. But I do also have concern that this is quite a broad group. Over.
Dr. Talbot, okay, is your hand down? Thank you. Thank you, Dr. Daly. I think what we should do is call a vote right now and see where things stand. This is not going to be an easy decision, but I appreciate the members providing all of their input and our liaisons as well. So ACIP members, a reminder to state your name, whether you have a conflict of interest, and then your vote on interim recommendation vote number 4. Dr. Alt.
Alt, no conflicts, yes.
Okay. Ms. Bata.
Bata, no conflicts, no.
Okay. Dr. Bell.
Bell, no conflicts, no.
Okay. Dr. Brooks.
Brooks, no conflicts, yes.
Dr. Chen.
Chen, no conflicts, no.
Dr. Saneas.
Saneas, no conflict, yes.
Dr. Daly.
Daly, no conflicts, no.
Dr. Cotton.
No conflict. I do not like this language, and I would prefer to delay the vote on this. But if I have to vote now, I would vote yes.
Dr. Lair.
Lair, no conflict, no.
Dr. Long.
Long, no conflict, no.
Ms. McNally.
McNally, no conflicts, no.
Oh, sorry, could you restate your vote? We lost you at the very end, Ms. McNally.
No, no.
We'll come back to you. For some reason, your audio is not working well. I will come back to you, Ms. McNally. Dr. Paling.
Paling, no conflicts, no.
Dr. Sanchez.
Sanchez, no conflict, no.
Dr. Talbot.
Talbot, no conflict, yes.
Okay. Ms. McNally.
Dr. Lee, I'm going to keep my camera off for this because I am afraid that my internet is not working properly. McNally, no conflict, no.
Thank you. Okay. Dr. Cohn, do you have the tally here?
You have to vote.
Oh, Lee, no conflicts. Yes, thank you.
I am counting 6. I'm counting 10 no's and 5 yeses. Is
Okay.
that what you? What did you count? 9 no's and 5.
2, 3, 4,
9 no's.
9 no's, 6 yeses. So the nays have it, and the recommendation is not passed. Dr. Cohn, does that seem correct?
Yes, we will, regardless, it doesn't pass, and we'll just confirm our yes and no votes.
Would any committee members wish to make a statement providing the rationale for their series of votes? We're opening it up right now. Dr. Talbot.
Actually, can I propose an amendment and a revote for the fourth vote?
Dr. Talbot, you would have to propose a new vote. This vote has not passed, so it would have to be a new.
Can we do a vote 5 then?
Give us a moment, Dr. Talbot, to confer.
That's fine.
Give me a second. So how about this? Ms. Bata, would you like to make a statement? And then we'll come back to you, Dr. Talbot.
Yes. I think, again, I feel like we're being pulled into an emotional decision, and this is an emotional decision, but we really do have to stay with the science. And the science shows that we have a really effective vaccine. And we aren't making a decision for unvaccinated. We're making a decision for vaccinated. And I don't think we have the data in these younger age groups to make a decision for a booster dose. To me, it would suggest that the vaccine doesn't work. And that we know that that isn't true, but that's how that message will be conveyed to the broader public. And that's why I said no to these last 2 votes. Thank you.
Thanks, Dr. Bata. This is Dr. Cohn. I just want to respond to Dr. Talbot. I think given the fact that we are already an hour and a half over our meeting, we're going to close this meeting.
Well, not yet.
Not now, but we are not going to open it up for additional votes. But we will consider bringing this issue back to the table with potentially different options. We have several meetings ahead of us. So we can keep going, Dr. Lee, with comments.
Okay, thank you. Dr. Alt.
I voted yes on the third vote because of what Dr. Freihopper said about allowing clinicians maximum leeway. And I think there were also some public comments and some things in the docket that said the same thing. And I voted yes on the fourth vote because of what Dr. Talbot said. I think we're both in an area where there's a tremendous amount of community spread, and all the hospitals, big and small in my region, are operating on the thinnest of margins. And for people to be sick or take time off of work, if their healthcare worker really is putting our systems at risk. And so that's why I voted yes for the fourth one.
Thank you, Dr. Alt. Dr. Bell.
Thank you. I just wanted to actually just agree with everything that Lynn Bata just said in explaining why I voted no, and also to say that, you know, I'm like a broken record here, but this is the beginning of a lot of activity around booster doses and other vaccination efforts that are going to be coming. And I think in this situation at this moment, given the lack of evidence that we have about the marginal benefit of booster doses for people in certain groups who received a Pfizer primary series, that this is too narrow, it's too soon, and that the potential risks or adverse outcomes of waiting until we actually know a little bit more about what we're doing and we can better assess the opportunity costs and the unintended consequences, that we should not be, in my opinion, there's little marginal benefit to making this booster dose available at this time, given all the other, all the unknowns and all the things that are coming up very soon in the future.
Thank you. Are there any additional ACIP members that wish to make a statement or provide an explanation about their series of votes? Dr. Paling?
All right, so during the 30 hours since this emergency meeting has started, approximately 2,500 Americans have died of COVID-19, and most of them were unvaccinated. This COVID-19 vaccine is the most studied vaccine in the United States. The development, extensive evaluation, and distribution of the vaccine, including one with such extraordinarily cold chain requirements, is an incredible example of what can be accomplished when we openly share data, collaborate, and work together to achieve a goal. What we have learned about COVID-19 provides tremendous hope for the future. We can get to the other side of this pandemic if we truly work together. And so it will require us all. The biggest impact on the pandemic that's been mentioned many times would come from increasing vaccine coverage with primary series and using the recommended measures. And so we have openly shared both what we do know and what we don't know. And we should highlight that there's a lot we do know. And we should highlight that the primary series is highly effective. There is waning for persons over 65. We're worried about the persons in the long-term care facilities and persons who are 50 years of age and older with high-risk conditions. And for those reasons, I voted yes. My most important thing we can do is make sure we don't take away efforts from the primary series. And so we want to provide additional protection for those at increased risk, but the primary protection is the most important thing we can do. Over.
Thank you, Dr. Paling. Are there any other members that wish to make a statement? I'm not seeing any hands raised. I would like to thank our speakers, our CDC colleagues, our members, ex officio members, and liaisons for a really incredible day, two-day meeting. I do want to just say that I really appreciate everyone's input and respect for diverse opinions, and hope that the discussions here are helpful to our colleagues who need to be able to explain policies and recommendations to their constituents. I anticipate that we are going to have another meeting very soon as the data continue to evolve and as things continue to emerge in terms of new updates. We will continue to update the committee. In the meantime, are there any additional business items that require discussion today, Dr. Cohn?
I just want to remind everyone about the non-COVID meeting that is occurring next week, I believe on September 29th. And that will be a full day of exciting updates and information about everything but COVID. If there are new data that we need to bring to this committee at that time, we can add something to the agenda during that meeting if we need to.
Thank you. And with that, I'm going to announce that today's ACIP meeting is now adjourned. Thank you, everyone, for your time, and we look forward to talking again soon. Bye-bye.